Right. The next item is a report on Winterbourne View. Jane.
Thank you. The board will know that I've previously reported on progress or lack of progress with the Winterbourne View Concordat, and since our last meeting, the 1st of June has passed, which was the time or the date that was agreed as part of the Winterbourne View Concordat that all appropriate patients would be discharged from inpatient settings. And as everybody knows and has been widely reported, that date was not delivered, and I think continues to be significant concern both to those of us around this table, but also, and perhaps more importantly, to people that are in inpatient settings and their loved ones. So we have put a considerable amount of effort into trying to both improve our delivery of those recommendations and actions, but also to think differently about how we move forward. It is clearly not straightforward, and it is clearly not something that can be done very easily. If it was, I'm sure it would have been managed better by now. So what we have done is we've reviewed what we've been doing. We have changed some of our internal governance processes. We have made very specific and detailed efforts to engage much more widely across our system. So, for example, the Commissioning Operations Directorate, CCGs and area teams have had very clear expectations set out about what we want to see delivered, and that information is contained in the paper. We've also now completed, as planned, a review of each of the 47 patients that were resident at Winterbourne View. That review has been carried out by our Improving Lives team, who are clinical experts in learning disability, and they have had, I think, significant success working with key partners, individuals and the people and their families, and have been very well received. And as a result of that, we have transferred patients out that were otherwise considered to be in long-term inpatient settings, and they are now being quite sought after in terms of being able to provide advice and guidance. So we are helping to support those key staff to continue to provide overview of patients with particularly complex conditions. I think we also, at the last meeting, reported that we were waiting for individual plans from CCGs and specialised commissioning teams about potential discharge dates. The results of those plans are that we have about a third of the inpatients with a planned date for discharge over the next 3, 6, 12 months. On one level, that is some progress, but I think most people, and I would imagine all of you, would agree with me that that is just not good enough, and it's not where we would want to be. So although I recognise that there is progress made, we still want to go further. So what we've been doing is looking about how we can both avoid admission in the first place, promote early discharge, and provide much better community services. And as a result of being working with third sector organisations, we have had 3 different sets of organisations that have provided us with ideas and suggestions about how we can take that forward. And we are proposing, and hopefully the board will support this, that we establish a sort of strategic steering group that will oversee the vision and strategy for how we can commission differently, working in partnership with third sector organisations and other experts in this field, to really have a step change in a completely different way in terms of, and moving it onto a different level, I suppose. There has clearly been quite a lot of work that's been done. We are beginning to see progress being made, but I think most people would suggest that that's not fast enough and that we want to go further. We also know that families, carers, and a lot of our third sector organisations, and in fact NHS England itself and Local Government Association, would welcome the opportunity to do things differently. I'm really pleased that Sir Stephen Bubb, who's the Chief Exec of Akivo, has agreed to chair that group. That group will involve key partners, key stakeholders, including clinicians and things like LGA. And we would aim to have an agreed full membership of that group and a timeline for delivery identified in the very near future, which we will look to promulgate and actually expand on and communicate widely with both key stakeholders, families, and another key partners. So that's a very brief overview. The paper is as you've got it, so I'd be very happy to take any questions and would welcome comments from the board.
Thank you very much, Jane. Questions and comments? Margaret?
Thank you very much, Jane. For me, the really critical point here is what happens with advocacy, because essentially what I think was a huge gap in process and procedure previously was people feeling that they weren't listened to, and indeed not being listened to and not being heard. I recognise that there is going to be scrutiny on the quality of advocacy. What I would like to know is what the oversight looks like, and can you give a bit more detail about the process around how we would oversee the improvement in quality of advocacy and also the response, the listening aspect?
Okay, so what the approach that that we're proposing is that we have almost a sort of two-pronged approach to this. That the sort of strategic steering group I've just talked about is very much about what the new future commissioning model will look like. And I think it's important that that group concentrates on that, but makes sure that there is very strong liaison and communication with some of the other governance arrangements that we've got in place. Alongside that, we will continue to deliver through our programme board, the Joint Improvement Board that actually already exists, the delivery of the ongoing day-to-day improvements that we're making, and advocacy is part of that. The advocacy role is also the responsibility through local government. About 97% of people have got advocates. I think we would like to see that strengthened in terms of the role. That's not to say that the advocates that are there aren't in many cases doing a good job, but we want the ability for individuals and their families to really feel that they've got somebody that will act on their behalf, that will put a challenge into the system, will call for additional help and advice, particularly from the Improving Lives team, for example. And we've got the ability to be able to provide almost an independent assessment of some of those patients that have been in hospital for a considerable length of time. What is it that's stopping us moving them? What is it about either clinical practice or about the local commissioning arrangements or the local services that's actually stopping us moving people when if they need to, if they should come out of an inpatient setting? So I would, I suppose the short answer to your question, as opposed to the slightly longer answer I've just given, is that I would say we will use the existing systems, we will use the Joint Improvement Board, and we will link that to the overarching governance arrangements that we've got in place to be able to make sure that we have a good accountability for all of the actions that are set out in Winterbourne View.
Can I just underline one point Jane has just made, though? In addition to the advocacy services, I think our aim is to get in place an independent second opinion service that every individual affected by the programme can have access to, so that they are not only reliant on the clinical advice they're getting from their local area. So are you able to say anything about what the process will be, timelines for putting in place that second opinion service? We've basically had some initial thoughts that have been provided by some of our own staff and other clinicians. I would hope that we can include that in the commissioning work that we're doing, so that we've got a timeline agreed as part of that work on the longer term commissioning function, because I would see that independent opinion being part of that in terms of enabling people to determine where they go. So I should have more detail about that in the next few weeks.
Okay.
Costed detail as opposed to just ideas.
Moira?
Malcolm, thank you. Just wanted to say how good it is to hear the additional oomph that Jane's leadership is giving to this, but we shouldn't begin to underestimate the scale of change required. And when we listened in our development session yesterday about innovative leaders, it was about people on the ground who were very familiar with it. This is more kind of commissioning, potentially feeling like being done too. So the importance of engaging all participants in the process is really important. But I did just want to say I was disappointed that in the whole of the conclusion, those 3 paragraphs, there isn't a mention of local government. This has to be a partnership and remain a partnership. I think the NHS has very significant resources in it, but the local government also has responsibilities, and I think Absolutely. I'm sure you will do that, and you've mentioned it a number of times, but it's just that they're not there.
Thank you, Maura. I think you're absolutely right. Local government is critical in this, and certainly as part of asking for them to be part of that strategic steering group, we already work very closely with them. I'm already part of a sponsors group where LGA are present. So yes, I absolutely agree. And in terms of your comment about this is about about not being done to, but taking people with you. Again, you're right. We already have quite a few good examples of how combined co-commissioning locally is having really positive impact. It's not everywhere. The variation is significant. And so I suppose one of the ways that we're looking at this is potentially through having some sort of a national framework, but that can be locally delivered. So providing people with not only the skills and experience, but the tools to be able to do something locally, making sure that what they are doing is really wrapped around every one of those individual people, because the needs will be different, and so having a national one size fits all for this group of people is absolutely wrong, and we would need to make sure that it's locally delivered with local partners. So
I have Victor.
Just, firstly, to welcome the approach, in the sense that certainly the third sector interventions or attempts to support this, the papers that I've read are very much about working with, not doing to, and just to support Maura's point, are very welcoming, wanting to engage with local government. I do think it's possible to create a national approach which produces bespoke outcomes, which is where we need to get to. We need the outcomes to be bespoke to individuals and their families and communities. I think it is possible to do that. I actually welcome the idea of a second opinion, because I think one of the barriers has been the sort of dispersed and sometimes, frankly, confusing clinical opinion about safety and whether people can move, and I think people have a right to seek independent view. I am optimistic about accelerating this process and indeed learning from it, so it becomes embedded in how people with learning disabilities receive commissioned services that they can be involved in. I think that the new era of commissioning is in my view, something that needs to move from something that's done to people in some mysterious place to something that they're involved in. Otherwise, it's not commissioning. So I think there's a lot we can learn from this process beyond just learning disabilities, frankly.
Margaret, and then
thank you, Chairman. I'll add to that. The collection of data coming out of the Concordat project, which I know is going to be transferred to HSCIC, should have, I suppose, appended to it an ambition, so that we are learning and we're using the learning, and I just think that as the data is transferred to HSCIC and we receive reports back, that aim, that ambition should, I suppose, dictate the way in which we receive the reports and what we get back from the data.
Yeah, yes, we can do that. The other thing we're looking about with because at the moment the data is quarterly, and it contains a huge amount of information. So by the time we get it, it's another 2 months post that date. So we're also, as well as looking at transferring the quarterly data through to the HSCIC, we're also looking at what we can have that is simpler to collect but more frequent, so that we've got some sort of monthly information to enable us to track. And actually, absolutely, it's about what we're trying to deliver, what are the outcomes we're trying to achieve, rather than just numbers. This is about people.
Yes, exactly.
So it's how can we use information to tell us what's happening to the people that we are supposed to be caring for.
Thank you.
No.
I wanted to ask Jane whether you would share the thought that this could be a very good example of agility and speed of response. And my thought is that, the capabilities that have been built over the last year, 2 years, in terms of co-commissioning systems and so on, whether it is potentially a good example of how we could respond quickly to what is clearly a gap in the system, because the capabilities that have been put in place allow us to do that. So the co-commissioning system, the ecosystem, for example, with the third sector. And my thought is whether, having had a report and then having had the Concordat and now establishing a steering committee to oversee implementation, does that approach respond to the expectations for speed of response and agility to this situation? And when do you think we'd come up with solutions and options that could be implemented?
So I did that. Your last question, are you talking about when we'll come up with solutions around what we're planning to do
from the
now?
steering group? I'm
Okay.
thinking, long-term system options.
Okay, so we need to finally agree this, but our expectation is that we will have some initial thoughts and initial plans and set out certainly during this autumn. I would, we do not, as Victor and others have already said, there is a lot of appetite out there for change. There's a lot of expertise within the system. I do not see why we can't actually harness that expertise and harness that enthusiasm and actually deliver something that's reasonably quickly. And we want to be in a position where we can influence certainly the commissioning decisions, planning guidance, etc. that we may want to put in place for next year. So I would aim that we would have something in the autumn.
Okay, Jane, thank you very much for that report, which is encouraging.